Hello and welcome to another edition of the Osteopathic Lyceum podcast. I'm going to speak through a very fundamental challenge to almost all hands-on healthcare practices. Something that I've repeated quite a few times is that all hands-on healthcare practices occur from the external environment of observation. There may be some circumstances in some jurisdictions whereby hands-on healthcare practitioners have access to the ability to order imaging, but even then, you're not necessarily observing the image. You're still, when you're working with that individual, observing from the outside. You can have some knowledge of what's inside that you can't observe without imaging. Usually, imaging doesn't tell you what to do, it tells you what not to do. If something is torn, you don't move it. If something is broken, you don't move it, because you could add further insult to the circumstance. So the imaging can be available to some, not available to others, available more easily. There's a variety there. But when the individual that you're going to work with presents themselves, you are outside of them. You cannot identify anything that's inside. This allows me for me to point to the difference between sign and symptom. A sign is essentially what anybody can identify, including the patient. So a runny nose is not a symptom. It's a sign because both the patient and the practitioner can identify the runny nose. The symptom is the thing that only the patient can identify. So they will have some form of report that nobody could really identify otherwise. Pain is a symptom. Pain is multifactorial. There are 3 categories which are now considered meaningful as far as investigation. So you have your nociceptive pain, whereby there is actual or possible damage to tissue, which is appropriately sensed by nociceptors and sent through the nervous system and processed in the brain. You then have neuropathic pain, where there is no possible actual damage to tissue, but there is some form of pathology of the nerve, so it is sending signals to the brain that do not properly relate to the state of the tissues it's sensing, but those signals are going to the brain. So there's a pathology of the nerve. Then you have nociplastic pain, where there is no neural pathology and there is no possible or actual pathology of the tissue, but the patient is reporting pain. All 3 of those are categories which are being investigated and further attempted to be understood so that we can interpret the symptom better. Now, the challenge with pain being a symptom is that it cannot be sensed in any direct way by anybody other than the patient. Therefore, any measure of pain that you utilize in your practice is at best a distant proxy. The person has to tell you something to corroborate any finding that it relates to pain, and you have no choice but to trust that that report is accurate. And sometimes it is, and sometimes it isn't, and sometimes they're more sensitive, and sometimes they're less sensitive. So it is a wildly variable symptom. It's a wildly variable report within a given patient and between patients. It cannot be sensed by the practitioner. So there's just this gigantic amount of problems that present themselves in relation to pain as a diagnostic criteria for hands-on practitioners. Hands-on practitioners are able to meaningfully identify gross differences in motions, whether it is a motion of a joint or many joints combined, a macro movement as I would call it, or yield to pressure of soft tissues. You squish into the soft tissues and they either squish like their neighbors or they don't. There's an area where there will be more resistance to the imparted pressure to which it does not yield. Right? So trying to say that properly. Basically, you go to squish it and some squishes and some doesn't. The spot that doesn't squish, that's the spot that has the resistance, is not appropriately responding in relation to its surroundings to the same stimuli. So the things that we can meaningfully and accurately identify are external things. They're proxies for internal things, but we can't really piece apart which things they're pointing to properly. But we can consistently, if we do it appropriately, identify what's moving, what's not moving, and we can interface with that in a trustworthy way where we get a regular range or a consistent range of positive outcomes. So all of that to point to where I'm going to say something, that if you are a hands-on practitioner, trying to interact with somebody with respect to pain as your primary diagnostic communication or their primary communication leaves you in a land that you can't properly interface with. You can develop sense, or you can develop experience that allows you to sense where things are not moving all that well. And then over time, with a bunch of reports, you normalize and you start to figure out, this seems like something that feels uncomfortable to most people when I encounter this. And you'd have to ask a lot of people, and you'd have to have a very, very similar set of reports. And then maybe you can trust it. But maybe also you can't. So you have to accept and acknowledge that not everybody feels the same about what you find. What you find is simply what you're able to sense with respect to motion characteristic. You can then, over a very long time, ask a lot of people the same question or similar questions so that you can get to similar information as to how does this feel. So you can get a sense of what is likely to be uncomfortable, but you don't necessarily know how much it hurts, who it hurts, why it hurts, because you can't sense the pain. In a relatively flippant way, I will often tell people, I can't feel your feelings because if I could, I would be feeling too many feelings. So it's a nice light way to basically say, yeah, I can't identify your pain. It's not what I'm working on. I'm working on what I find that is moving or is not moving. And I'll proceed to the best of my ability from there. So if you are a hands-on manual practitioner and you are trying to use any internal sensation, anything that would be symptom-based, you're making a fundamental attribution error. You are essentially saying that from the outside, I can feel what they feel. That is inappropriate. It's not how we're wired up. They can tell you what they feel, and you can try to put that together clinically over time across a large amount of encounters with a large amount of highly variable people. But because it's normalized data, it's easy to make assumptions and miss the outliers, which is one of the reasons the barrier concept is so interesting, because it allows you to interface with the person in the moment. Because what you're really looking for, I say don't make them say ouch, but over time, as I've thought about this more, I think it's more appropriate to say you don't want to elicit any protective responses. Those protective responses would often look like some form of verbalization, of an abrupt verbalization. I say abrupt because I can't say that it's about pain, but I can say an abrupt verbalization to any abrupt-ish movement, an abrupt contraction to an abrupt movement, or an abrupt face to an abrupt movement. And we could sort of, in all likelihood, characterize those as the category of protective responses to any imparted movement from any practitioner. You're trying to avoid protective responses. The barrier concept lets you control that if you're making decisions based on avoiding protective responses. And that is unique to osteopathy as a profession. It doesn't mean other practitioners in other professions don't do that. It just means that as a central piece of osteopathy, it's there. And as the other professions, it's just not there as central to the identity and practice of those professions. So many practitioners may do that. They may avoid the protective responses, but it's not necessarily a highlight or a hallmark of those other professions, where it's a highlight and a hallmark of osteopathy, especially when it's properly adhered to. So instead of looking for the pain response and because you can't really sense it, or attempting to chase the pain because you can't sense it, in saying what I've said already, I'm acknowledging that you can identify protective responses to some degree. You try to avoid protective responses. You don't try to treat them. You try to avoid them, because if you avoid them, you don't elicit them. You don't get the normal set of responses once you're done. So anytime a pain response or a protective response is elicited in the short term, there's often a normal set of responses subsequent, such that the next day there would be predictable soreness, predictable pain, something of that nature. Not absolutely, but something of that nature. So if you think you're finding and treating pain, you're making a fundamental attribution error. What you're finding is motion restriction, and you're relating it cognitively to pain, whether you're correct or not, because you're probably always a little bit off. As I've said, you treat lots of people, you ask them, you encounter a similar sensation to you, you ask all of these different people, and maybe most of them point in the direction of it's uncomfortable or it's painful, right? Now, in saying that, I must also acknowledge that the way that I talk about the barrier concept, don't make them say ouch. You're actively looking to avoid protective responses. You're actively looking to avoid things that could be considered painful. So it governs how you move. So you're not treating the pain. You're trying to avoid eliciting pain. You're not treating the protective response. You're attempting to avoid eliciting the protective response. And you're really focusing on movement. So you're just trying to figure out where you can move that person meaningfully and respectfully so that you avoid those protective mechanisms. So osteopathy as a profession has this inbuilt mechanism that allows you to treat movement because it's what you can find and what you can work on, and avoid protective or pain responses. But you're not treating the protective or pain responses. What you're doing is you're attempting to not elicit them subsequent to your interface. It's probably the best way to try to describe it. So all this talk and all this rambling to, again, return to the point. If you're a hands-on manual practitioner, you can't treat symptoms. You can treat signs. The primary sign, because you're in the external environment of observation, is movement, gross movement, or yield to pressure of soft tissues. If you stay there, you're probably very accurate. If you stay there and in the way that you do that with the person in the moment is guided by attempting to avoid protective responses, you are further probably very accurate, probably improving movement, probably not creating subsequent soreness, and you're appropriately interfacing with the patient at the center of what you're doing because you're looking to avoid responses that you can identify. When somebody says they're in pain, you have no choice but to believe them. All signs may point to they're not, but you have no choice but to believe them because their report is their report. Whereas that's not going to clinically help you because you can't feel their feelings, you can't feel their pain, but you can find the things that are and are not moving and appropriately respond to those. So again, to reiterate, you're in the external environment of observation. Movement is your thing. You can identify it, you can work with it, and you can't feel their feelings. So attempting to interface with their feelings is inappropriate. A way to discuss this with people prior to treatment is to say that you have a scale and I have a scale. My scale is movement. Your scale is how you feel. Sometimes our scales cross over properly, and other times they don't. So if my scale improves, I did my job properly. If you move better, I did my job properly. But it may not be the solution to your feelings, to your scale, because they don't properly relate. When they properly relate, it's fantastic, they change together. But it's not because I'm looking to change how they feel internally. It's because I'm looking to change the movement, and the movement appropriately relates to what they are feeling. So if you focus on movement, you're probably accurate. If you focus on how they feel, you can't be accurate because you're always going through multiple proxy lenses that have the opportunity for misinterpretation, miscommunication. So stay away from attempting to talk about and advertise that you treat pain because you don't. You, as a related feature of working on movement problems that you can identify, are able to impact pain as a hands-on manual practitioner working from the outside. So if somebody tells you that they're sore, and you're a hands-on practitioner and you use, say, an electrical modality, you throw TENS on them, really you'd probably throw IFC on them, you throw IFC on them, and then they say they feel different, like, well, yeah, they had an intermediary experience of a very different sensation for a period of time, then that is stopped, or there's cessation of that new novel stimuli of the electrical current, and yeah, they feel different, but the question is, did it do what you wanted it to do? Did it make mechanical change, or did it just introduce a novel sensation so that they're now interpreting through the lack of that novel sensation? It's up for question, and for some people, IFC is absolutely fantastic. For some people, TENS is fantastic. For some people, something like ultrasound is fantastic, or at least the way that it makes their scale feel. But clinically speaking, it's movement that you can identify and you can interact with. You know, the person says it's ouchy right here, you put the ultrasound head up there. Sure, maybe it makes them feel different, but also maybe it just is a novel sensation for a period of time, and when that stops, They feel different than the most recent thing of the cold ultrasound head in the gel doing whatever it was doing. So we would want to piece between, or sort of negotiate between, is it you felt one way, we did something novel, that stopped, now you feel different than the novel. It's worth talking about, and it is worth utilizing under many circumstances, because if the patient knows that it does something positive for them, you can work on it that way. But the primary clinical interface is going to be the external environment of observation. You find what moves and what doesn't move. You interact with that, and it either relates to the pain or it doesn't, or relates to the sensation or it doesn't. So the fundamental attribution error being that from the outside of a patient, you can find internal sensations. You can't. You can't feel what they're feeling. So do yourself a favor and focus on the movement. You'll be more accurate. You'll have more positive outcomes for your scale, which is the movement scale. And when it appropriately relates to what the patient is feeling, it will change. Now, I will say from clinical experience, it often relates exceptionally well. So you often end up having your scale as the practitioner and their scale as the patient improving. Realistically, it always matters most that their scale improves. You're just trying to use your skill set to see if the match happens. So thank you for listening this far. Hopefully you took something away from that, which is basically don't chase somebody's feelings because you can't feel them, you can't identify them. Work on movement, and if it properly relates to what they're feeling, it's a match made in heaven. So thank you again, and we'll talk again soon.